Very good morning and warm welcome to Online Anaesthesia Postgraduate Teaching Program on Zoom platform, sponsored by IDRA and hosted by A1Logics and aired by Sarva TV. Today we are having two important topics in pediatric anesthesia: anesthesia for neonatal emergencies and fetal surgeries. Further, we have two learned scholars in our online anesthesia platform. I welcome Professor Dr. Rajeshwari, Subramaniam Madam, and Dr. Anju Gupta to online anesthesia platform. Today's program is going to be coordinated by Dr. Sarva Vinothini. Over to you, Madam.
Good morning. Good morning, everyone. It is indeed a great privilege today to have two wonderful speakers. The first speaker is Dr. Anju Gupta. She's an assistant professor in NAIMS, and her areas of interest are pediatric anesthesia, regional anesthesia, and airway management. She has more than 14 years experience of working as a faculty in various institutions. She has underwent an airway management course in London, and she's a recipient of numerous awards, has more than 150 publications to her names, and she's even authored more than 33 chapters in books. And she is an editor of Barrage Clinical Anesthesia and Dosh and Dosh Southeast Asian edition. She's an assistant editor and associate editor in various journals like IJA, Frontline Pediatrics, etc. She's an executive board member of IAPA National, and she's an Indian representative for EDRA International Executive Committee. And she's a founder secretary of Neonatal Anesthesia Society. Who else would be the apt person to speak to us regarding the neonatal surgical emergencies? So here, Dr. Anju Gupta ma'am is there to enlighten about the neonatal surgical emergencies and the anesthetic considerations in that. We welcome you, ma'am. Over to you, ma'am.
Thank you, Sarva, for the kind words. Am I audible? Am I audible?
Yes, ma'am. Yes, ma'am. Audible, loud and clear.
My slides are visible?
Ma'am?
Slides are visible?
Yeah, yes, ma'am. Yes, ma'am. Visible, ma'am.
Okay. So thank you, Sarva. At the outset, I would like to thank Edward Johnson, sir, for giving me this opportunity and this platform to present to you a very important topic of neonatal emergencies. So neonatal anesthesia, as all of you would agree, it is the most challenging subspecialty of pediatric anesthesia. And this puts them in a very high-risk category. So today we will understand the common emergencies which we as anesthesiologists face, which we all need to be aware of, because there are a lot of differences in physiology, pharmacology, pharmacodynamic responses. So, and most of the complications, they are attributable to the lack of understanding of these basic considerations. So I would not go into the nitty-gritties of the neonatal basic differences, physiology, pharmacology and all, and which have been aptly covered by the previous speakers of this series. And so today my aim would be to take you through to 5 most common neonatal emergencies. We will speak about tracheoesophageal fistula. We will speak about congenital diaphragmatic hernia, gastroschisis, and we will also speak about this omphalocele and hypertrophic pyloric stenosis. So we always when we are taking up the challenge of anesthetizing a neonate, we should be aware of the possibility of sudden changes in the hemodynamic and pulmonary parameters. We have to expect the unexpected. We have to always think about any unknown congenital problem. These can always arise despite the patients being evaluated preoperatively. So every neonate has a unique requirement for specific equipment, IV access, fluid and drug therapy, anesthetic dosages, environmental control. The temperature is a very, very important aspect of neonatal anesthesia. The temperature control is very important. And neonate who are presenting to us for emergency surgeries, they can present several difficult challenges to the anesthesiologist. You can all imagine neonatal anesthesia itself is a very, very challenging field. And when they present to us for emergency surgery, the challenges, they become multifold. they multiply to several times because we do not also have the time for optimizing them and evaluating them well. So this neonatal anesthesia, the preparation itself takes a lot of time, and we should not compromise on the preparations. And during the anesthesia, we should be constantly vigilant, and we should quickly recognize any onset of any adverse events, and we should swiftly intervene. So preventing any eventuality, any catastrophe is the most important aspect of that would be a constant vigilance, because early recognition of these complications can prevent a catastrophe. So coming to the first emergency, which is the congenital tracheoesophageal fistula and the esophageal atresia, it is the commonest, one of the commonest anomaly which the neonates would present to us. So tracheoesophageal fistula is nothing but a communication between the trachea and the esophagus. And the esophageal atresia is basically a failure to form a continuous passage from the larynx, from the pharynx to the stomach. So the incidence is about 1 in 2,500 to 3,000. So it is quite a common anomaly. And 20 to 40% of these infants are premature. And they are also small for gestational age. And mind you that all the complications, they are much more prevalent in the premature as compared to the term neonates. So there is a hard trachea, while the lower esophageal pouch has an upper blind end. Then this is the one, type C, which is present in almost 86% of cases, where the upper esophagus, it ends in a blind pouch, and the lower esophagus is communicating with the trachea. Then the type D, where both are communicating, whereas type E is a kind of H type of fistula, which we say, where the trachea and the esophagus are communicating while there is a continuity of the esophagus. And there is also one type F described, where there is only esophageal stenosis. So another classification which has been described is the Vought classification, which is more or less similar, but there are minor differences. It classifies as type 1 to type H or the type 4. The type 1 is the esophageal agenesis, where no esophagus has developed and there is no fistula, whereas type F is the esophageal stenosis. So we need to be aware of the associated anomalies and the comorbidities which are present in these infants, and they are the highest in the isolated esophageal atresia. So whenever such esophageal atresia presents to us, we should be very skeptical about the presence of additional anomalies, which are present in up to 50 to 70% of these cases. And these are least in the H type. And mind you, the commonest cause of death in these patients is the associated cardiac anomalies like tetralogy of Fallot. So we should be aware of these. Among the cardiac, the VSG is the commonest, then PDA, tetralogy of Fallot, ASG, right-sided aortic arch. We should be aware of the presence of right-sided aortic arch because it will change our management, the surgical approach. Then GI, GU, musculoskeletal. Then vectoral anomaly is a constellation of syndromes, which are anomalies which are present with this tracheoesophageal fistula, and it is relatively commonly seen whenever there are any of these anomalies. Then we should be vigilant about the additional presence of this constellation. We should look for these additional anomalies. This vectoral, it stands for vertebral, anorectal, tracheoesophageal, renal, radial anomalies. And it has been, it was initially mentioned as VETR, then it was expanded to include the cardiac and the limb anomalies. And then there is I will speak about this in the next slide. Then there is a CHAR syndrome, coloboma, heart defects, atresia cone, then retarded growth and development, genital hypoplasia, ear deformities, Potter's syndrome, Scheisses. When we can see some of these anomalies, then we should look for these additional anomalies so as to know that this child fits into this syndrome. Then respiratory tracheobronchomalacia is associated, which will change our management. Tracheal agenesis, stenosis, tracheal upper pouch. Then genetic anomalies, trisomy 21, that is Down syndrome, and these can be associated. So vectoral is the one which which can be seen commonly, and it basically refers to the vertebral. Vertebra can be hemivertebra and some other anomalies in the vertebra, agenesis and other problems. The sacral agenesis, these all can be vertebral associated anomalies. Then scoliosis and other kyphosis, these things can be associated. Then anorectal malformations, then cardiac anomaly, then tracheoesophageal fistula, and renal and limb anomalies. Renal absent one kidney, these are commonly seen. So when a child presents with a anorectal malformation combined with a tracheoesophageal fistula, which you sometimes must have seen, so such a child should be evaluated for the presence of these other anomalies. Sometimes the child, even I have got done when the child was combined, posted for both the repairs. So then tracheoesophageal fistula and anal anomalies are present, then generally the child would be diagnosed as a case of vectoral. So the most important, ultrasound should be ordered to identify additional renal and genitourinary anomalies. So coming to the management, such a child, whenever this condition is diagnosed, whether it is a small setup or any other big setup, such a neonate is always posted for surgery. So such a neonate, since neonates should always be operated in a tertiary care center with a NICU care, so the child is referred to a neonatal to a tertiary care center. Then we should always keep such a child NPO. We should avoid feeding. We should maintain a good hydration by providing isotonic fluids. Then such a child is, earlier the child used to be placed prone with a continuous suction of the nasogastric tube. Nowadays, generally they are kept upright or semi-prone position to minimize the GERD. Then we should protect the lungs from aspiration pneumonia by all these measures, continuously, intermittently suctioning and irrigation of the upper pouch. Then such a child should be posted for early surgery. Generally, it is said that in the first 24 to 72 hours, the child should be operated. And the antibiotics are administered to prevent the pneumonitis. And if pneumonia develops, then we should always treat it urgently and before the surgery. So this was the tube which the postgraduate students should be familiar with. This is a Rapoglay tube, which was earlier used most. I have had a word with my pediatric surgeons. They are not generally using this kind of tube nowadays, but it is mentioned in the text and in the textbooks. So basically, it is a tube with two lumens. One is for attaching the suction tubing, and one is for injecting the saline and the air. And here the aspiration of the saline which is entering is done, and it is aspirated continuously. So it is the child is put on continuous suction. So surgery is a emergency surgery. So it is relatively not like emergency surgery to be taken up within hours. The child can be optimized for some time and can be posted after 24 hours of life. So gastric distension, but the child has to be taken as an immediate emergency when the gastric distension is such that it is compromising ventilation, and we can see the evidence of aspiration. That is the gastric content in the ETD. For healthy and stable neonates, generally they are posted after 24 hours. And staged repair is done in neonates who cannot tolerate a full surgery, like in neonates who have a multiple congenital anomalies, and the cardiac conditions are such that the child would not be able to undergo and tolerate that period of anesthesia. So in such cases, staged repair is planned. If there is a gasless abdomen, which is suggestive of a proximal or a absent fistula, in such cases, generally preemptive gastrostomy and delayed repair is planned. And cervical esophagostomy in our institute, generally cervical esophagostomy and diversion gastrostomy is done. So surgical techniques, if the patent distal fistula, which is the most common condition, then generally open surgical repair is done, but which is by right posterolateral thoracotomy, fistula ligation and creation of the primary anastomosis. However, there are some surgical complications which are known to happen, like chest wall deformity, scoliosis, and fusion of the ribs. Then minimally invasive techniques have now come in vogue, like thoracoscopic repair, but they are generally done at very advanced centers by skilled surgeons. So the advantage is that it provides excellent visibility of the anatomic structures like azygous vein and vagus nerve. These all are clearly seen. So that reduces the morbidity. So what are the major challenges in front of us when we are managing a case of tracheoesophageal fistula? It is the presence of aspiration pneumonia, associated congenital conditions, overdistension of the stomach, which will lead to inability to ventilate, and the need for postoperative ICU care. So anesthetic management starts with the preoperative evaluation. We should take a detailed history of the neonatal course till now, like the mode of delivery, the feeding history, any previous family history. Then systemic examination should include the presence of dysmorphic features like facies, which will suggest a difficult airway management, cardiovascular and respiratory problems. And laboratory investigations would include the blood investigations, chest X-ray, ECG, and ABG, sorry, not ECG, ABG, to identify the current lung condition and to determine if OLV will be tolerated well. Like for thoracoscopic surgeries, one lung ventilation may be needed. Then echocardiography may be ordered in cases where we are suspecting condition, and if it is possible, it should be done for all the cases. So it should be to identify the coexisting cardiac anomalies and to rule out vascular anomalies, especially the right aortic arch. In such a case, the surgical approach changes from right thoracotomy to the left thoracotomy. So it is very important to know. Then ultrasound study will include ultrasound KOB and CNS to rule out additional anomalies. Then there are certain risk assessment scores which have been described, which will basically suggest the prognosis of the child and some surgical decisions. So in this Waterston classification, which was the earliest one, it was used most commonly. It was based on the birth weight and the additional comorbidities. So the group A was when the birth weight was more than 2.5 kgs and there was no complication. Such a child could undergo surgery straight away. A child with a weight between 1.8 kg to 2.5 kg and no complication can also undergo surgery, but a child may need some stabilization. A child more than 2.5 kg with moderate pneumonia or congenital anomaly will need stabilization before surgery. Type C, when the child birth weight is less than 1.8 kg with no complication, will still undergo staged repair. And more than 2.5 kg with severe pneumonia and congenital anomaly will go for staged repair. This is one Montreal classification. All of this basically you need to be familiar with, and sometimes they are asked in the exam. So the postgraduate student should go through these classifications. Group 1 is isolated major anomaly, isolated dependence of the mechanical ventilation and presence of non-significant anomalies. And group 2 is based on severe anomalies and dependence on mechanical ventilation. Then this is a Spitz classification for prognosis. This is another very commonly used classification. The more than 1.5 kg with no major anomalies, with the advancement of technology and other advancement in the knowledge of the pathophysiology, now it has been seen that the survival rate for any infant who is more than 1.5 kg without any major anomaly can go up to 97%. So this is the Spitz et al. They mentioned the survival rate of up to 97% in 1994. And all the survival rates have gone up in 2006 when they were assessed by Lopez et al. Because of the presence of better drugs, better techniques, and advancement of technology. So now less than 1.5 kg or any major anomaly, if these conditions are present, still the survival rate can be 82%. And if both are present, then survival rate can still be 50%. So there is a lot of improvement in the survival rates. This is the most recent one, Okamoto modification. They have mentioned that class 1 with more than a birth weight of more than 2 kg will have 100% survival. Class 2 with birth weight less than 2 kg with no cardiac anomaly will have a 81% survival, and birth weight more than 2 kg with major cardiac anomaly have a 72% survival but have a relatively high risk, and those with major cardiac anomaly and less than 2 kg will have a low survival. Now coming to the intraoperative period, the monitoring would include the standard ASA monitoring. Temperature definitely should be monitored, and then precordial stethoscope is one thing which is additionally useful in this condition, because the child is placed in the thoracotomy position, and then sometimes the monitors, if they stop working, then we are in a soup. So this precordial stethoscope, they allows a breath-to-breath monitoring to determine the ventilation to the dependent lung. Sometimes what happens is that the tube may migrate, because we place the tube very distally, then it is very likely that even small movements or intraoperative stretching of the structures can make the tube migrate. And also, like in cases where we have achieved a one lung ventilation using, say, using any this isolation devices, even these balloons, they can come out or they can migrate. So it is very important to place a precordial stethoscope in the axillary line in the dependent side. Also, the cardiac sounds, they can be monitored and they can be seen. If they are muffled and the blood pressure is showing as low, then cardiac output has fallen down and it can suggest some conditions. Then upper and lower is we should always place two pulse oximeters. Why it is important? Because sometimes the conditions, cardiac conditions, may be undiagnosed or misdiagnosed, and it will placing a preductal and postductal pulse oximeter. Preductal means what? A right extremity pulse oximeter, and postductal anything beyond that. So if we place that, it will suggest a shunting. Then arterial access can be through umbilical in neonates, or it can be a radial artery. So if this is commonly indicated for children who are hemodynamically unstable, who have congenital anomaly associated and significant lung disease, and urine output can be monitored. So thoracotomy is the most common right posterolateral approach is used. So extrapleural dissection is done through 4th and 5th intercostal spaces. And in this position, we should always be attentive to the changes in the airway pressures and tidal volumes and ATCO2. We should always prevent hypothermia by employing all the measures. And one more very important thing is that when the fistula ligation has been done, the surgeon would ask us to re-expand the lung. So sometimes people do it very forcefully, and it should never be done. It should be re-expanded slowly to eliminate the atelectasis. Thoracoscopic repair, the positioning is different. The child is positioned in a prone position with a wedge below the right chest. Operatic pneumothorax compresses the ipsilateral lung. So you should be aware of this, that most of the cases the surgeon would still not ask us for OLV. Most of the cases, the surgeon, the pneumothorax, which is created pneumothorax, the operative pneumothorax, it will compress the ipsilateral lung, and so OLV may not be needed. But this can lead to desaturation and fall in the venous return. And CO2 which will be insufflated into the thorax, can lead to hypergarbia and acidosis. Airway management is a very important aspect for anesthesia. So earlier, awake intubation was recommended with topical anesthesia. We are now aware that there are some risks associated with this technique. So nowadays, either it is not done or it is done as a awake sedated intubation. Then another thing is inhalational or intravenous induction with spontaneous ventilation, or with use of muscle relaxant and gentle positive pressure ventilation. So size of fistula and compliance of the lung would determine which kind of airway management we will go through. Awake intubation has it is done under topical anesthesia. So the obvious advantage is that we will not need the positive pressure ventilation, which can insufflate the stomach prior to the ligation of the fistula. However, it is easier said than done. And also there is a poor glottic view, and the child can still desaturate due to the airway handling. And also this has seen to increase the risk of intracranial hemorrhage. So that's why it is not favored nowadays. So inhalational induction or intravenous induction with a spontaneous respiration is one of the advocated technique. It avoids the positive pressure ventilation, and negative intrathoracic pressure allows the gases to preferentially enter the lungs rather than the fistula. And we always have the option of awakening. However, the lungs are poorly compliant and the adequate gas exchange may not be possible. Now coming to the apneic intubation, I had a word with many pediatric anesthesiologists, and I'm sure they also mentioned this, and majority of us are using muscle relaxants because it provides optimal airway condition which minimizes any airway trauma. It, however, necessitates the use of positive pressure ventilation. So what can we do? There is a term known as controlled rapid sequence induction, which you postgraduates should be familiar with. This is basically the use of gentle positive pressure ventilation after neuromuscular blockers, that is maintaining an airway pressure of less than 12 centimeter of water. Nowadays, we have closed circuits and we have the airway pressure monitors, so we can always restrict our pressure, airway pressures to this pressure, which will minimize the delivery of the inspired gases to the stomach. So the tube used can be cuffed with Murphy's eye or a microcuff tube. They have the advantage which I will come on to later on. And the position of the tube, it is said that optimal position of the tube is distal to the fistula and above the carina, and the bevel should be facing anteriorly because it provides an additional wall which can cover a distally placed fistula. So positioning of the ETT, when the ETT is generally, endotracheal tube is generally placed endobronchially, it is deliberately pushed into the bronchus. It is deliberately pushed into the bronchus, and another assistant would be auscultating over the lungs. And as soon as the air enters the lung and it is not present at that time, we auscultate over the epigastrium, and the stomach is not being insufflated. That is the right point of fixing our tube. At this point, the bevel is turned anteriorly so that we get an additional amount of the wall of the tube. So there are some additional approaches which have been described, like fiber optic guided intubation. It has an additional advantage that we can visualize the fistula and place the tube distal to that. Then if there is a large distal fistula, like if there is a pericarinal fistula, which is a very big fistula, then we can do bronchoscopy and we can use Fogarty catheter or bronchial blockers to block the fistula, and this can be followed by the endotracheal intubation. However, it is easier said than done, and this Fogarty catheter, the placement before endotracheal intubation, it can be very tricky in these small neonates, especially preterm neonates, and this can even come out while the surgery is going on. So we need to, it is done, but we need to be very skilled in this, and we need to be aware of this complication. Then endobronchial intubation in the left main bronchus. This is done in many cases, and sometimes in emergency, then it can be done and to achieve one lung ventilation, but the child should be in good condition to tolerate one lung ventilation. Then there is a one suggestion of using a cuffed endotracheal tube, like we take the tube distal to the fistula and we inflate the cuff, and it has been suggested that it will block the fistula. Let's see. So this is one of my reports where a child who was 9 days of life, he presented with a large precarinal tracheoesophageal fistula and bilateral pneumonitis for tracheoesophageal fistula repair. So in this case, the child had a bilateral pneumonitis, so lung compliance was obviously very poor. So when we ventilated with a uncuffed tube, we were not able to do it. Then a microcuff tube was used, and it was taken distally, and though I did not use a fiber optic bronchoscope, I did a deliberate endobronchial intubation and then pulled it out and then inflated the cuff. So it blocked the distally placed fistula very well. Why? Because microcuff tube, the cuff is placed very distally, more distal than the conventional endotracheal tubes. So in this case, it came to our rescue and we could then ventilate. So this was another concern. This is another concern. This happened to me in another case where we did the conventional bypassing of the tracheoesophageal fistula by deliberate endobronchial intubation. But what happens is when there is a distally placed fistula and you have placed the tip very distally, sometimes with the surgical positioning and pressure, the tube might, be touching the carina. In such cases, the pressures will be rising and you will unnecessarily be looking for the conditions, what happened to the child. And then you will be ruling out other conditions. But it was a very simple thing that it was touching the carina and it can increase the airway resistance and it can stimulate the carina and other complications, even spasm can happen intraop. So it can become a very tricky situation. So then in this case, we did a fiber optic bronchoscopy to rule out a distally placed fistula. So it was seen that the fistula was very distally placed, because if we were withdrawing it for a millimeter, then the gastric insufflation was happening. So it has been seen in previous studies also that in many cases the fistula lies within 1 centimeter of carina, and in some cases it is even bronchial in origin. So we should be aware of this fact, and we should be vigilant, and ideally we should use preoperative bronchoscopy in all tough conditions to so that in cases where there is a large distal fistula, it can alter our airway management accordingly. Intraoperative concerns, surgical manipulation, as all of us who have been managing these cases, surgical manipulation can alter the hemodynamics and VQ mismatch can happen. Accidental fistula intubation can happen, which can lead to gastric insufflation. And in one case, this has led to mortality. There is one report that the fistula was accidentally intubated. Then accumulation of the blood and secretions can obstruct the ETT. So in cases the pressures are rising, then ETT suctioning should be done and this thing should be ruled out. Then careful manual positive pressure ventilation after fistula ligation. As I mentioned that if you do it forcefully, it can lead to development of a pneumothorax. Then complication, surgical manipulation of the lungs can cause significant disturbance of the hemodynamics. The cardiac output can fall, especially in cases where there are associated congenital anomalies. Then in these cases, we have to ask the surgeon to stop for a while. We re-inflate the lungs. We allow the hemodynamics and the saturation to come up to improve. And then we can allow the surgery to happen. So retraction can even occlude the trachea and the bronchi. Just one thing which I want to mention here is that the neonatal trachea is very compliant. The tracheal cartilages are very, very soft. So any pressure on them can occlude even the trachea or the bronchi. So, and then after fistula ligation, the anesthesiologist may be asked to perform positive pressure ventilation. So we should do it very slowly. Azygous vein needs to be tied off for exposure, and rarely the IVC drains directly into the right atrium via the azygous vein. So in such cases, when the azygous vein is ligated, the child can become unstable. So this is one of my cases where I faced complete loss of ventilation in 2 cases. I just wanted to mention because it is a very rare cause. So in one case, what happened was that the surgeon had accidentally transected one of the bronchi instead of the fistula. So we should be aware that these kind of things can happen. So whatever we were ventilating, it was jetting out through the surgical incision. So there was complete loss of ventilation to the fistula, to that bronchus, which had been transected. So immediately what I did was, how I managed was that I pushed the tube into the bronchus in a desperate attempt. And luckily it went to the other bronchus and I could ventilate. And quickly the surgeon ligated that bronchus, and then it was the condition we could control. Then another thing was that in some cases, the surgeons use these kind of obturators to locate the fistula. So after intubation and placement in the lateral position, we just inserted this red rubber tube and into the blind upper pouch. This helps them for easy location of the fistula. But in this case, they inadvertently handed over a big red rubber catheter. So this big red rubber catheter, as soon as it was inserted, within seconds, the ventilation was lost. So what was happening was that it was pressing onto the trachea and there was a complete loss of ventilation. So then coming to the analgesia, which is also very important, we should provide a good analgesia to these kids. Generally, multimodal analgesia and local infiltration is a commonly practiced technique with opioids and non-opioid analgesics. However, nowadays, a lot of regional anesthesia techniques are available, like intercostal blocks, which can be very easily done blindly. So they are easy to do, and they can easily be it can easily be done by the anesthetist or the surgeons. Then paravertebral block. This is one thing which we were practicing some time back. Like surgeons go through extrapleural approach, so they can just retract the lung in the end, and they can just infiltrate some amount of local anesthetic in the paravertebral space. So this can be easily done. Then intrapleural infusion, I don't think it is commonly practiced. Then caudal epidural analgesia, I have also practiced, and it can be done. Caudal approach to epidural space can be utilized, and the catheters can be threaded in the thoracic level, because in neonates the space is very fluid, and the catheter goes like it is a very cakewalk to just thread in the catheter. It is very easy, so it reaches the thoracic levels, and then continuous infusion can be started, or conventional epidural space can be accessed through lumbar or thoracic. It can be, though it is relatively, thoracic is definitely a very, very rare thing in children. The tip should be in high thoracic level. So post-operatively, should we extubate, should we not? It depends on the prematurity and pre-existing weight of the child and the comorbidities, the duration and the ease of the surgery. Sometimes the surgery is very complicated and complex, and then there is a tension on the anastomosis. The surgeon would prefer the child to remain ventilated, and the quality of pain control. So post-operative ventilation is generally indicated for any neonate less than 2 kg in preoperative respiratory distress, significant cardiac pathology, and esophageal repair when it was in tension. So post-operative NICO monitoring should be done, pain management and elective ventilation can be done. Now coming to the next important anomaly, that is the congenital diaphragmatic hernia. For all the postgraduates, any of these conditions can come to you as a long question. So it is possible that any of these neonatal emergencies, and it is commonly asked question, one of these conditions will be given and you will be asked to discuss the management in detail. So the incidence is 1 in 4 to 5,000, and there is a male preponderance. Among the type of hernias, the posterolateral hernia from the foramen of Bogdelok, that is the commonest, because there are embryonic this pleuroperitoneal channels which may remain patent. So this is the commonest hernia which is present in 80% of cases. Then it can be paraesophageal. Anterior from the foramen of Morgagni has been described in 2%, though it is very, very rare. And then right-sided hernia is definitely very, very rare. So embryologically, the appearance of lung buds to the bronchial opening, it happens in the 4 to 17 weeks. And diaphragm, the closure of these channels happens in 4 to 9 weeks of gestation. And the gut migration happens at 9 weeks. So if there is a delayed closure of the pleuroperitoneal canals, so then this gut migration, it fails to happen. Associated anomaly, we should be watchful for these anomalies. There can be trisomy 13, 18, 21, and there can be some syndromes. Among these syndromes, this Beckwith-Weidman, we should be watchful, and Goldenhar and these other syndromes, they have been mentioned. But serious anomalies are seen in many cases, in up to 50% cases, which can be a patent ductus, septal defects, AV valve defects. So we should be watchful for all these anomalies in all such cases. So pathophysiology, abnormal lung development, pulmonary hypoplasia, abnormal pulmonary vasculature. So when the pulmonary vasculature is abnormal, there can be a persistent pulmonary hypertension of newborn. And visceral herniation into the thorax, what happens? It leads to atelectasis of the systemic and atelectasis of the lung and the systemic hypotension because of the pressure on the heart and the great vessels. So hypotension and atelectasis will happen, and the lung hypoplasia happens if the gut has migrated into large amount of gut is there in the thoracic cavity since early gestational age. So all this will combine to lead to hypoxemia. So there are some predictive scores which we need to be aware of. Prenatally, if the lung to the head ratio is found to be less than 0.8, it has been seen that there is 100% mortality. And if it is more than 1.4, there is no mortality. Postnatally, if the gestational age is less than 33 weeks and the weight is less than 1 kg and cardiac anomalies are associated, this is a very, very risky condition. Then Bones nomogram, it is one nomogram which has been described, and you need to be aware of this. There is 100% survival in children who have less than 40 PaCO2 and ventilatory index, which is the mean airway pressure multiplied by the respiratory rate. It is less than 1000. So initial resuscitation, this condition is never presented to us as a very rarely does it present as an emergency. It is generally nowadays said that it is not a immediate emergency, and we can stabilize the child well before the surgery. So such a children who has a severe condition, they can be intubated and mechanically ventilated with a lung protective strategy, and we should always avoid bag mask ventilation to further worsening the condition. So lung protective strategy: low tidal volume, high respiratory rate, peak airway pressure less than 25 centimeter water. Pre-ductal saturation, the aim is to keep it from 85 to 95. We don't aim for 100%. PaCO2, the aim is for slightly hypercapnic, permissive hypercapnia, that is 45 to 60. And the pH should be aimed for more than 7.3. Resuscitation and stabilization, the child is nursed in a semi-upright and semi-lateral position. Decompression of the lungs is done. Vasopressor appropriately are used. Serial monitoring of the ABG and the electrolyte are done. And maintenance of the body temperature is of paramount importance, because hypothermia can worsen the pulmonary hypertension and which will lead to further worsening. I'm sorry, this has come again. So alternative ventilatory strategies. If the conventional ventilation is requiring higher pressures, and if there is a evidence of pulmonary hypertension, and if the progressive hypercarbia, hypoxemia, and pulmonary hypertension, these are worsening, then we can use the alternative ventilatory strategies. We can use high HFOV for high peak airway pressures. For high pulmonary artery pressure, we can use inhaled nitrous oxide. And for in case there is a progressive hypercarbia which is not responding to your this conventional ventilation, then we can go for ECMO. Anesthetic management, there is a classical triad. These children will present with dyspnea, cyanosis, dextrocardia, apparent dextrocardia because of the pushing of the heart to the other side. There will be dyspnea, tachypnea, cyanosis, chest retraction. These signs will be there. Birth history of prematurity, congenital anomalies will be there. And treatment history, we should always elicit what all treatment have been received. Clinical examination will reveal the presence of respiratory distress, and sometimes even gut sounds can be heard in the thorax. And on X-ray, this classical picture of gut in the thorax, it can be seen. The air-filled gut will be seen in the thorax. So laboratory, all general investigations are done along with the ABG, and air-filled viscera will be seen in the mediastinum. And echo, we should always get an echo done for assessment of myocardial function, pulmonary hypertension, and concurrent heart defects and shunting. So we should always obtain a good IV access, and we should always decompress the lung decompress the stomach before we start our anesthesia. We should always monitor the child for preductal and postductal pulse oximeter along with standard monitors and precordial stethoscope. Then post-induction, we should always place a temperature probe, capnography, urine output. Radial artery line can be placed at a lower threshold in this case. And central venous access in children who are very, very sick. These can be obtained. Mind you that venous access should preferably always be obtained in the upper limb. Because after the reduction of the contents into the abdominal cavity, the pressures may rise and the lower limb congestion can happen. So this intraoperative management, the choice of anesthesia, most of the cases awake is not done, though it is recommended. Modified RSI with a succinylcholine and rocuronium or awake intubation is recommended. So modified is what? That limiting our airway pressures to very, very low. If apnea can be tolerated, that is the best. Then isoflurane and can be used for maintenance. However, nitrous oxide should logically be avoided because it can lead to distension of the viscera, and that can lead to further shifting of the mediastinum to the other side. Then volume or pressure controlled ventilation can be used while limiting the peak airway pressures to less than 30. Analgesia can be obtained using IV opioids, which is commonly used, or similarly, as I mentioned, that caudal approach to the thoracic level can be used. And warming should be continued very aggressively because any amount of hypothermia can worsen the pulmonary hypertension and it can worsen the condition. Intraoperatively, some complications can happen which we need to be aware of. Acute desaturation can happen. We should always suspect pneumothorax on the unaffected side. Sudden hypotension can happen due to the RV failure or kinking of the major blood vessels, and also due to abdominal compartment syndrome if it happens after the reduction of the contents. Hypothermia can happen and we have to prevent it aggressively, and hypoglycemia also we should prevent. So postoperatively, the postoperative ventilation is indicated in large hernias, but we should not hyperventilate and we should aim for PaO2 more than 150 with the least possible FiO2. And we can slowly wean the child from over next 72 hours. We should be vigilant of presence of a abdominal compartment syndrome. I will come to later. Honeymoon's phenomena is nothing but a early smooth course in postoperatively, followed by a sudden development of pulmonary vasoconstriction and fatal pulmonary hypertension. So take-home points is that the left posterolateral hernia is the commonest. Lung to head ratio of less than 0.8 can point towards 100% mortality. The child present with classical triad of dyspnea, cyanosis, dextrocardia, apparent dextrocardia. Modified RSI is generally preferred. Acute desaturation, if it happens intraoperatively, we should suspect pneumothorax on the unaffected side because of the presence of pulmonary hypoplasia and use of high airway pressures. And if sudden hypotension happens, we should be wary of RV failure, kinking of major blood vessels, and abdominal compartment syndrome. Now coming to the abdominal wall defects. The common defects are gastroschisis and omphalocele. So since the management is more or less common, I will discuss them together. So embryologically, though they are unique, but the management is essentially same. Omphalocele is due to the failure of the loops, bowel loops, to re-enter the abdominal cavity at 10th week of life. Bowel herniates into the umbilical cord between 6 to 10 weeks and re-enters by 12 to 14 weeks. Now, gastroschisis is due to, gastroschisis is completely different embryologically. There is an abnormality of the right omphalomesenteric artery or right umbilical vein, which leads to dysplasia, complete atrophy of the abdominal wall, central abdominal wall, and right umbilical hernia area gets ischemic and the bowel is completely out of the abdominal cavity. If it develops later in life after the gut has returned to the abdominal cavity. Say this gut was already there in the abdominal cavity, but due to the ischemia of the paraumbilical area in the right side, the gut comes out of the abdominal cavity. There is an inadequate mesoderm. So these are the two pictures of the classical pictures of omphalocele and the gastroschisis. You can see a clean hernial sac in this omphalocele because it is covered by the amniotic membrane. And the umbilical cord, it is directly attached to the sac. So it is major problem will be is the replacement of this content into the small abdominal cavity, because the abdominal cavity has not had the opportunity to develop because the gut content have been outside, so it has not sufficiently developed. In this condition, gastroschisis, there is the gut is injured because there is a matting, foreshortening, and the peeling of the gut covering, and there is no clean membrane or amnion which is covering this, and the umbilical cord is lateral to this. Umbilical cord is away from this anomaly, this gut contents. So the difference is that the incidence is rarer for omphalocele is rare. Gastroschisis is rarer. Sorry, Omphalocele is 1 in 4,000. It is around 1 in 10,000. The pathology we have discussed. Defect is open and inflamed edematous ball. Whereas in omphalocele, the gut is intact, the amnion is covering, and the peritoneum is inside. The associated anomalies, however, are rare in gastroschisis, and we should always be watchful for anomalies in case of omphalocele, which are present at a very, very high incidence in omphalocele. Defect size is slightly lesser in gastroschisis. It is much more in omphalocele, and the umbilical cord is adjacent to the defect, whereas it is in the apex of the defect. So the associated anomalies, the cardiac defect is the commonest, which is present in 30 to 40% cases. GU anomalies, chromosomal anomalies, these all are present. I have seen one case of Beckwith-Wiedemann syndrome with omphalocele. It is a triad where omphalocele is present and visceromegaly is present and hypoglycemia is present. So if you see some kind of indication for visceromegaly, in my child, the tongue was very large, which made us suspect this condition. Hypoglycemia was also found later on. So immediate management for omphalocele, the gut is covered by a bowel, is covered by a sac, and it is semi-urgent. Since it is covered, so the heat loss and the water loss, it is slightly less. So surgery, however, is indicated because unless it may become urgent in case the sac ruptures. In gastroschisis, the bowel should always be covered with cellophane to reduce the evaporative losses, because the evaporative losses can become very high and these children can be very, very dehydrated. So we should resuscitate these children preoperatively. We should prevent hypothermia because the gut is exposed, and we should provide IV fluids to rehydrate the child. We should give nasogastric tube and aspirate and decompress the gut contents. And antibiotics should be started. And in gastroschisis, it is more of an emergency surgery. So gastroschisis stage surgery is common. Why? Because I had told you that the abdominal cavity has not had the opportunity to develop well, because the contents are outside. So the abdominal wall may not be sufficiently developed to accommodate these gut contents. Stage reduction, first stage is stage reduction of the herniated bowel loop using a cystic pouch. So these kind of cystic pouches are used. These are commercially available, and complete closure is done later on. So these gradually the gut contents are pushed inside as a bedside procedure. Also, this can be done gradually. The contents are pushed inside, and in some cases, when in intra of when the gut content were reduced, what happens is the abdominal pressure they increase to such a level that the child cannot be ventilated. In such a patient, silo can be placed, and gradually the contents can be moved inside. So spring-loaded self-retaining elastic pouch is available, which can be used as a bedside procedure, and defect can be closed later. Anesthetic management, we should always obtain a history and rule out congenital anomalies. We should do a complete examination to assess the fluid status and the respiratory distress. Then we should come to the investigations, laboratory investigations, and anomaly workup by use of X-ray and echo. Then preoperative management, fluid resuscitation is given by fluid is given at a much higher rates of maintenance of 150 to 300 ml per kg per day. Urine output, we should aim for 1 to 2 ml per kg to ensure good hydration. Then monitoring clinical and electrolyte and acid-base status should be monitored preoperatively. Normal thermia should be maintained, and lesion should be covered with a non-adherent dressing and a plastic cover, which will ensure that evaporative losses are not happening. Decompression of the stomach should be done, and sepsis should be treated by antibiotics. We should always avoid direct trauma to the herniated organs, which may include even the liver, and evaluation of the congenital heart disease and other anomalies should be done. Airway and respiratory assessment should always be done. As I told you, in the case of Beckwith-Wiedemann syndrome, it was a very difficult airway because the tongue was so large that it was protruding out of the oral cavity. Gestational age, birth weight, and should be seen. Then anesthetic management, preoperatively, aggressive fluid resuscitation should be done. Serial monitoring of ABG and electrolytes, avoiding heat loss, and care of the exposed organs, prevention of the infection, good antibiotic cover. These all are our responsibility also. So we should also go and visit and ensure that these things are done. For surgical management, intraoperative management, OT preparation, all neonates, you should always invest a good amount of time in preparing the OT. Warm the theater, increase the temperature to 27 to 29 degree for a term neonate, and for a preterm neonate 29 to even 31 degree. And prepare active warming devices and IV fluids. Venous access, similarly in this case also, should be secured in the upper limb. Gastric decompression is done before induction of anesthesia also, and standard ASA monitors and temperature probe, capnography, urine output, CVP and should be done. Now in this case, additional monitoring which will be useful is the indirect intra-abdominal pressure measurement by use of intravesical pressure. They are used as a surrogate for intra-abdominal pressures. Choice of anesthesia, similarly in this case, modified RSI are used, and maintenance of anesthesia by using isoflurane routine. But in this case also, we will avoid nitrous oxide, and we should always consider all the regional anesthesia options which are possible. Then adequate neuromuscular blockade can be used to facilitate abdominal closures. Fluid 10 to 20 ml per kg can be used. Then active warming should be used. In historical times, gastroschisis, there was a series by Wayne et al. Where they mentioned spinal anesthesia for gastroschisis. But these were the times when the technology and the drugs were not adequately developed. So this was considered a safer options. But in these times with the availability of all the advanced things, this thing is a rarely reported technique. So we need to be aware of the criteria for safe abdominal closure. Once the surgeon is nearing the closure, then we will be discussed whether it is safe to close the abdominal fully by reducing the contents, or it can be done in a staged repair. This is an important decision which needs to be made at this time. So we need to be a party to this decision. How we can, if we are using a intragastric pressure or intravesical pressure, these are a surrogate marker of intra-abdominal pressure. We have to limit it to 20 millimeter mercury, and then peak inspiratory pressure prior to abdominal closure should be less than 35. End-tidal CO2 should be less than 35, and urine output should be more than 0.5. These all will suggest a good pulmonary compliance, relatively acceptable pulmonary compliance, and a good systemic circulation. Post-operatively, any increase in intragastric pressure to more than 20 millimeter mercury or CVP of more than 4 millimeter mercury above baseline was found to be associated with reductions in venous return cardiac index and used to be associated with the surgical decompression of the urgently requiring the surgical decompression of the abdomen. So this is a sign of abdominal compartment syndrome developing, and we should be watchful in the post-operative period also. So infants with large defects, they should be sent to the NICU, and they should be extubated post-surgery slowly. So complications, abdominal compartment syndrome is the one most specific thing which is associated with this condition, and we should be watchful in post-operatively. Hypothermia, dehydration, hypoglycemia, lower lobe atelectasis, these all things can happen. So to summarize the anesthetic concerns, the child would be dehydrated. There can be massive fluid loss because of the exposed viscera. There can be heat loss. There can be difficulty of surgical closure. There can be a high associated prematurity, congenital defects, especially with the omphalocele, and cardiac anomalies. So during closure, we should consider, or we should always keep an eye on the airway pressures, and difficulty in ventilation should be considered. Hypotension should be considered as a sign of increasing abdominal pressure. Increased abdominal pressure will compromise the liver function, and this can alter our drug metabolism. So when the closure is being done and these things are happening, the compartment syndrome is developing, or some liver is being compressed. So what will happen is the drug metabolism will be altered, and this can lead to compromise in the liver function, and our drug metabolism will be altered and delayed recovery can be present. So during closure of the big defect, we should try to monitor the bladder pressure or the intragastric pressure, and we should attempt to maintain it below 20. Now coming to the last anomaly for today, that is the hypertrophic pyloric stenosis, also known as idiopathic hypertrophic pyloric stenosis. It is the hypertrophy of the circular muscle of the two circular layers of the pylorus. So there is a hypertrophy which develops. So at 3 to 6 weeks, this child will generally present with a projectile vomiting because of this hypertrophy. There is a gradually developing obstruction and projectile vomiting will develop, and the non-bilious stomach contents will be vomited out. And there will be the child in these 3 to 6 weeks, the child will show an absence or the failure to gain weight, and the child will gradually become very dehydrated. The stomach will be dilated. And on abdominal examination, sometimes these children used to present late and dehydrated condition. If we palpate the abdomen, this hypertrophied pyloric mass used to be palpable, and this was known as an olive kind of mass. So nowadays, these kind of things are not required. Ultrasound can easily diagnose this condition. So what are the main anesthesiology concerns? The child will have a full stomach. Sometimes barium studies were done in earlier days. Nowadays, these are generally not done. But if a child has immediately after barium surgery been posted for surgery, then you should be wary of a full stomach due to barium also. Otherwise, also they are known to have a full stomach. Then metabolic alkalosis is a condition, and then we will come to it why it is so. Hypochloremic metabolic alkalosis, hypokalemia, and severe dehydration. So coming to the pathophysiology, what happens is due to the projectile vomiting, there is a loss of water from the in the gastric contents. So the child gradually becomes dehydrated. Dehydration leads to stimulation of aldosterone secretion. Further potassium loss leads in the urine leads to worsening hypokalemia, and kidney excrete the hydrogen ions, the sodium in the water. So there is a acidic urine. Still there is a acidic urine. What happens is ideally the kidney should excrete the bicarbonate. Initially they excrete the bicarbonate, but due to the further loss of potassium, then this aldosterone is secreted. Then this kidneys, they try to preserve the water because of the worsening dehydration. So they exchange the hydrogen ions in exchange for potassium and sodium. So they excretion of the hydrogen ion, then this leads to a acidic urine. So we need to be aware that this condition in alkaline urine may not be seen. It can still be a acidic urine, which happens in the later stages. And logically, because there is a loss of sodium, chloride, and potassium and hydrogen ions in the gastric content, these all are present in gastric contents. So there will be a development of hypokalemic, hypochloremic metabolic alkalosis. So initially there is a loss of this bicarbonate ions to compensate for the metabolic alkalosis, but later on the kidneys, they excrete the hydrogen ion also. So there will be a worsening of the metabolic alkalosis. Always mind you that this is not a surgical emergency. It is considered a medical emergency. So metabolic correction is mandatory before surgery. It is not that it is a general kind of condition where we have to optimize the metabolic profile. The more importantly, the metabolic alkalosis, it can lead to respiratory depression and apnea. This will be aggravated by our general anesthesia drugs. So metabolic alkalosis is necessary that we should correct it to an acceptable level to avoid respiratory depression and apnea. This condition has been found to be at an increased risk of postoperative apnea even in term infants, though the apnea will be more in preterms. So alkalosis must be corrected prior to the surgery. The patient is kept nil by mouth, and maintenance fluids are always started, and maintenance fluid should be containing sodium, chloride, and potassium at the rate of 150 to 150 ml per kg per day. So after this hydrating the child and providing these electrolytes, once the alkalosis has been corrected, the fluid input is reduced to 100 ml per kg. And these are the acceptable biochemical findings before posting the child. The pH should be almost in the range above the pH of 7.3, chloride in the acceptable range, base excess in the almost the normal range -4 to 2.5, and potassium should be targeted to be in the normal range. Now, this is ultrasound has come to our armamentarium. So pre-operatively, even we can use ultrasound to look for the full stomach and diagnose a full stomach, and we can then aspirate and see whether it has been deflated. So this is the picture of a full stomach in a hypertrophic pyloric stenosis child. We can see a starry sky appearance, which is classically seen with the liquid in the stomach. And this is the liver margin. Now the stomach has been emptied. You can see this hyperechoic dot in the center, which is basically nothing but the nasogastric tube. So pre-operatively, the acceptable bicarbonate concentration is less than 30 milliequivalents, and chloride should be at least more than 100 to ensure that hypochloremic metabolic alkalosis has been corrected. The stomach should be emptied, and in this condition, it is important to aspirate the stomach in all the positions, beginning from supine, left lateral, then prone, then right lateral, all the conditions. If it has been seen that if we do it in all the positions, the stomach is effectively deflated. So, but importantly, we do RSI in these children. So we should remove the NG or OG. It is a general consensus that we should remove it before induction and reinsert it after induction. So RSI with propofol and muscle relaxant can be used. We should ensure good depth of anesthesia and neuromuscular blockade, because even if we aspirate the stomach, it is never almost completely deflated, and laryngoscopy can lead to stimulation. If it is done in lighter planes, it can stimulate the regurgitation and aspiration. There should be minimal narcotics should be used. Why? Because I have told you that these children are very prone to development of post-operative apnea. So opioid sparing or opioid-free techniques have been described for this condition. By use of regional anesthesia like rectus sheath block, rectus sheath block has been seen to be very effective. It covers this area well. Tab block can be used. The superior tab block can be used. Local anesthetic wound infiltration is obviously an option, and awake extubation should be done. So to summarize, this is a medical, not a surgical emergency. This is vomiting can lead to hypochloremic, hypokalemic metabolic alkalosis and dehydration, which should always be corrected. Because it is not a surgical emergency, we can always have a time to optimize these conditions. And these conditions, if they are not corrected well, they can lead to postoperative apnea and complications. We should ensure hydration and correction of electrolyte abnormality to a bicarbonate level of less than 30 and chloride more than 100. Stomach should be emptied before induction, and good depth of anesthesia should be ensured to avoid any regurgitation, and minimal narcotic should be used. So survival in these conditions is ascribed to increased knowledge of pathophysiology of these conditions. I cannot overemphasize the importance of good vigilance, good awareness of the pathophysiology, and adequate preoperative optimization in all these conditions.
Is very critical after the delivery of the baby, and we give general anesthesia in the majority of mothers. On the other hand, for fetal surgery, which is done in the mid-second trimester, it can be done with regional techniques also. And here the uterus requires to be kept paralyzed or relaxed for a minimum of 72 hours after the procedure, and the pregnancy is allowed to continue till 37 weeks. And then there is an elective cesarean to deliver the baby. So we'll first talk about fetal surgery. So by minimally invasive procedures, we can treat a large number of fetal conditions are treated. So through endoscopic procedures, tracheal occlusion plugs can be put for congenital diaphragmatic hernia, vesicoamniotic shunts can be placed, and the cord can be sampled for blood. And occasionally, meningomyelocele repair can also be done just by endoscopy and aortic valvuloplasty. The more major laparotomy and hysterotomy, that is the mid-trimester major procedures, are done for sacrococcygeal teratomas, which are growing at a very rapid rate, and for formal myelomeningocele repair, which are not amenable to the endoscopic repair, and for congenital diaphragmatic hernia correction in some centers, and for excision of large lung or cardiac tumors. Before proceeding for fetal surgery, which is going to be done in mid-trimester, it's very, very important that everybody should be on the same page, and the mother should be counseled in a very unbiased manner. Sometimes it is, our wish to rush through procedures because we are interested in doing it, but one must remember that it's the mother, in this case, who is the innocent bystander. She is going to undergo everything for the sake of the baby. So it should be made very sure that the mother is not going to suffer any harm. And surgery should not proceed until full informed consent is obtained. And if the fetus is viable, that is ages more than 24, then the mother should also be told that in case the baby needs to be resuscitated or needs to be emergently delivered, it should be done. So when we assess these mothers for fetal surgery, we take a normal preoperative history and examination, including symptoms which point towards other morbidities. We examine the airways, spine and vascular axis, and then the routine laboratory assessment. But here we have to take a very, very proactive role in the imaging studies, because it's very important for us to have an estimate of fetal weight in order to calculate the drugs and also have an idea of where the placental borders are located, as you'll see in the next few pictures. Whatever anesthetic we choose for minimally invasive fetal surgery, that technique should ensure that the mother and fetus are stable and the mother is very comfortable. And there should be a pre-planned method of tocolysis, which is relaxation of the uterus. The fetus should not be allowed to have any pain and should be immobile. And the tocolysis should be of that variety which can be maintained post-procedure. And we should always remember that general anesthesia may be required at any point of time. So for the procedures which I mentioned just before this, for the table, local anesthetic infiltration of the maternal abdominal wall is usually sufficient because these trocars are very small. They are only 1.2 to 2 millimeters in diameter. And a good endoscopist who can locate the placenta and make a clear pathway for the trocar does not cause the mother any pain. However, we might supplement maternal analgesia and angiolisis by using some midazolam or low-dose propofol infusion. And this can add to fetal immobility via placental transfer. However, if the placenta is anteriorly placed, then the patient has to assume a lateral position. If she has to be in the lithotomy position for a long time, or if multiple trocar sites are envisaged, it is probably better to give the mother neuraxial anesthesia. So this is the OT setup figuratively for fetal surgery. As you can see, there is so much of apparatus surrounding the mother, and the mother's head side is also all covered by video monitor and the ultrasonography monitor. And there are pumps which can infuse the amniotic fluid back or infuse saline into the amniotic sac. And there are a lot of people surrounding the patient, which includes the surgeon, the endoscopist, and the nurse. So I will just give you a few picture examples of these minimally invasive procedures. The first one you see is intrauterine sampling, which is probably the simplest. It just takes about 5 minutes. Here, the endoscopist passes a spinal needle into the umbilical vein and samples it. This is to diagnose intrauterine anemia and then carry out the transfusion. The second you see on the right-hand side is called the twin-to-twin transfusion syndrome, or TTTS. Here there is a twin pregnancy, but unfortunately there is a twin which is large and it is getting much of the cardiac output, and a very small child which is not getting any. But this larger twin is going on circulating the blood twice in itself. So ultimately, this child will also die of cardiac failure and the other child also will. So here the endoscopist will nicely ablate a few vessels so that extra vascularity to the big twin is stopped. This is now the most trending technique in minimally invasive fetal procedures. As Anju had mentioned, when these children, the head to lung to head diameter is done, then a 0.8 cutoff value, she said, was important for survival. But for inserting the plugs for congenital diaphragmatic hernia, a cutoff of 0.6 has been used. And it has been seen that these very severely affected children actually do well. How does one calculate the wellness is by their number of days on the ventilator and by the fact if they require extracorporeal membrane oxygenation or any other support. So again, and then the baby is allowed to again proceed to term. Sometimes, of course, this is combined as an exit procedure and the plug is also removed when the baby. Here, part of the amniotic fluid is removed and a slight amount of carbon dioxide insufflation is done so that the area of operation is kept dry. The amniotic fluid is kept warm, and then under vision, the membrane is used to close the dural defect. However, this is possible only for small meningomyelocele. If a child has got obstructive uropathy, it ultimately lands the child into a huge problem because you'd be surprised to know, but that by the 9th week, all the amniotic fluid in the body, in the uterus, is the baby's urine. So urine output is very important to keep the amniotic fluid volume correctly and also to ensure that the lungs mature. As you can see in the small infant's picture on this here, you can see that because of the rapidly increasing size of the kidneys and the hydroureter, the lungs become very small. Also, because of very little fluid in the amniotic sac, the child assumes a very flexed position and they develop flexion contractures. They develop a very hypoplastic facies and renal failure. And some of them may also develop the prune belly syndrome. So this condition has to be diagnosed very rapidly. And when the endoscopist sees a large bladder, which is called megacystis, then a vesico-amniotic shunt can be again done through minimally invasive surgery. A few children have large sacrococcygeal teratomas. There are many types. The type 1 is one which has got a well-defined pedicle and is completely outside the pelvic cavity. These are very amenable to laser ablation. And here the vascular supply can totally be cut off so that the baby grows properly. In children who are prenatally diagnosed with aortic stenosis, aortic balloon valvuloplasty can be done. And although this is a very light picture, you can see that this is the mother lying here. And the endoscopist actually directs the trocar. During these minimally invasive fetal procedures, the mother has to have standard ASA monitors. And every mother is given one single dose. The fluids have to be very, very restricted because the amniotic surface is a large absorptive surface, and there have been many reports of pulmonary edema when women are transfused more than 1 liter or 1.5 liters for these procedures. And with the aid of a spinal needle, fentanyl 20 microgram per kg can be given intramuscularly to the fetus to aid analgesia and immobility. So when we're talking about these minimally invasive procedures, there is one thing important to situation of the placenta. So in a mother where the placenta is posterior, the procedures which I explained to you just now are very easily done because the anterior wall is free. And so these can be done under local infiltration or some kind of spinal anesthesia also. However, for the same procedure, if the placenta is anterior, then the mother needs to have a laparotomy and the uterus has to be exteriorized. So for this is usually not tolerated very well with spinal anesthesia. So general anesthesia may be required depending on the placental position, and hence our proactive role in determining where the placenta is, at least. So here is the minimally invasive where although the technique is minimally invasive, the procedure for the mother may be very difficult. So the mother may actually require GA for tolerating such positions. Fetal move, intrauterine fetal manipulations and surgery, because a needle which is displaced can cause trauma or bleeding or even compromise umbilical blood flow. So maternal remifentanil has been recommended, and in countries abroad where remifentanil is available, this is the standard medication to use, 0.1 microgram per kg per minute as infusion to the mother, and the intramuscular injection or umbilical venous injection of a combination of muscle relaxant and fentanyl. So this has been seen to ensure fetal mobility, especially where the situation is very critical, like laser ablation, where the laser beam should not hurt or procedure. So now coming to the open fetal surgery in the mid-trimester. So this is done mainly for repair of meningomyelocele, large ones, debulking of large sacrococcygeal teratomas, congenital diaphragmatic hernia repair, and large intrathoracic masses which are compressing the heart. We may all not know this, but it is very important to operate on spina bifida, which pushes down the brainstem, leading to a Chiari malformation. So there is a existing Chiari malformation which allows CSF to accumulate in this myelomeningocele. And if the surgeon does not bother about it and just closes this, then the child will immediately die of coning. So normally, meningovalvular repair is also combined with a ventriculoperitoneal shunt if this procedure is done after the child is born. However, if the child presents to us in mid trimester, then in centers exposed and they get exposed to the amniotic fluid, which is not at all a healthy fluid, and the motor dysfunction occurs to one level above the cord involvement. Unfortunately, when these children grow up, they have a lot of learning disabilities and also loss of bladder and bowel control. So in utero repair has the potential for decreasing these neurological deficits and reduces the intrauterine exposure and improves the quality of life. So open repair of myelomeningocele is required when it is a very large defect, and here the patient has been subjected to a laparotomy and a hysterotomy. You can see that this is the uterine wall through which the baby's back and the meningocele is just seen to protrude. This is the MRI of the child where you can see the Chiari malformation, and this is the myelomeningocele. So here is a picture of a procedure actually. So this is the uterus and this is the pericardial mapping. The amniotic fluid has to be continually repeatedly in exit, all the more because it takes these. So since the exit was being done for the first time, we had a lot of visitors into the OT, and soon the OT was filled with people who who were just watching and wanting to have some fun, and it was very tough to chase them away. So OT arrangement and OT rehearsal is very, very important. And then the mother has to be for an exit procedure. It's a very, very major procedure, and the mother has to be assessed and counseled for the whole procedure. So we normally take a lot of pains to tell her what all we'll be doing. And we have to see whether she is already on tocolytics, which is a very high probability. And if she already is on magnesium sulfate, she's going to be very, very sensitive to relaxants and may have even CNS depression. So maternal anesthesia, when we give general anesthesia, as I highlighted before, it affords airway control and oxygenation, gives us a lot of time, and is useful if there is sudden postpartum hemorrhage or if the patient has to have an emergency hysterectomy. Sevoflurane and desflurane are recommended, and isoflurane is not very well recommended because it adds to a lot more of fall of pressure and because of its action on the peripheral vascular resistance. And a lot of authors have used epidural analgesia as adjunct. So to produce tocolysis, deep inhalation anesthesia of 2 to 3 maps of sevoflurane or desflurane are given, which is initiated 10 minutes before uterine incision. And fetal bradycardia may occur with very high concentrations of desflurane. We must watch out for it. Propofol and remifentanil have been used in mothers who had malignant hypothermia. And nitroglycerin infusion at the rate of 0.5 to 1 mic per kg per minute can be used to supplement tocolysis. It can result in reflex tachycardia and tachyphylaxis, but more worrying is that it can cause pulmonary edema in mothers who are susceptible, especially who had a very long exit procedure with a lot of amnio infusion. So the high doses of anesthetics and the nitroglycerin are very, very potent. They produce maternal hypotension in a very severe manner and also set the scene for severe postpartum hemorrhage. So we have to manage it very, very aggressively with phenylephrine boluses, occasionally with norepinephrine, and have blood cross-matched ready in the blood bank in the event that we need it. So epidural anesthesia alone has been sometimes used for exit. And in a very obese person here, remifentanil was used with combined spinal epidural. But whatever said and done, definitive airway control is a must for the mother. It makes us very comfortable. The fetal preparations also have to be very, very ideal. The OT temperature, the airway equipment, monitoring, and also the drug in proper dilution. We have to be ready to attach the monitors to the neonate very, very quickly. So a very concerted team is successful, whatever series are there in the literature. So there is an airway algorithm for the management of teratomas, which I have slightly modified. So if direct laryngoscopy can lead to intubation, then we can complete exit. If intubation is not possible, then rigid bronchoscopy can be done. And if it is possible, then a tube can be inserted and then again exit can be completed. But there are instances like our first baby where we could not do it with the rigid bronchoscopy. We could not even do it with the tracheostomy. And after that, we had to again come back all the way to intubate. So although exit is multidisciplinary, involving pediatric surgeons, neonatologists, obstetricians, and ENT surgeons, it is the anesthesiologists who are involved in the OT planning, maternal anesthesia, tocolysis, in fact, the whole of exit. And we conduct the multidisciplinary procedure much like an orchestra is being conducted. So we have to be very, very careful. There's no limit to how careful we have to be. So mortality without fetal surgery is very high in complex anomalies and in airway anomalies. And fetal surgery in selected indications can improve the quality of life in these babies. The exit is a very safe and effective way of securing airway, and more hospitals should start doing it. It requires a very orchestrated teamwork and planning. The anesthesiologists play the pivotal role and should be involved well before delivery. And we are the best people to intubate in OT conditions. So thank you very much. And I'm really very sorry for all the glitches that I produced. Thank you, Vinothini.
Thank you, ma'am. It was really nice having to hear from you. Those glitches are nothing for those videos that you have shown us. We had a first-hand experience of what you experienced. Thanks for those wonderful videos, ma'am. Amidst that, those glitches are nothing, ma'am. And you had proved your stewardship role in these procedures also. And it was wonderful to see those procedures. A few questions, ma'am. Any role of rectal indomethacin given preoperatively as a tocolytic agent, ma'am?
Rectal indomethacin has been reported, but although there is the problem of premature closure of the ductus, so whenever we talk about indomethacin, we look at the fetus, and especially the very small fetus. And it's actually a very fine way of balancing, because there are centers, as I said before, fetal surgery is still not very, very popular. So in fact, after the initial exuberance, now people are becoming much more watchful and careful of the selection. So in case the baby doesn't have a very high chance of survival and we're going to add a closed ductus to it, it's not a very good thing. But there are people who use indomethacin as an adjunct for tocolysis.
Yeah, and any role for atosiban? I got to read about atosiban in a journal, some oxytocin antagonist. Is it available here? And
no, it is not available. Thankfully, we don't have it here. Otherwise, we would have added more confusion.
Okay,
we are quite okay with our nitroglycerin. And when you give that 18% desflurane, it is something to be seen, to be believed. First of all, one would never imagine that one can give 18% desflurane. So giving that and nitroglycerin, the uterus is like a cloth. So, when they touch the abdomen, so they go by palpation. So it is just as if you can sink your hand right into the myometrium. There's no tone at all. And so we are so scared of the PPH. So they use the hormone. And so we are so scared of the PPH. So it's a tightrope walk, but it was very good because I think we learned so much. And subsequently, we've done 3 more. So all
stapling device is used to cut the to make an incision.
Hemostatic scalpel, like the harmonic
scalpel. Okay.
Scalpel only. Yeah. So they just keep on sealing the uterine wall as they go down.
And phenylephrine is the preferred vasopressor in the mother, and if at all required, norepinephrine. Am I right, ma'am?
Norepinephrine we didn't need to. Nowadays, norepinephrine, there's a low threshold for using it anyways, because after its use in sepsis or septic sepsis-like scenarios, so it has gained its ground even for maternal postprandial hypertension. But having said that, phenylephrine is a more predictable. We know what 50 mics will do, so it's more like that. But then it can actually very seriously reduce fetal cardiac output. Although these are conditions where we're not dealing with that so much, but I don't know, there are no studies or no comparative studies. But phenylephrine is definitely preferred and used.
Any role for cardiac output monitoring in the mother, like transesophageal echo, or any role for that?
In the mother, it is not the cardiac output which is, bothering us so much. I mean, it is the placental perfusion. So probably, something which can say whether the uteroplacental flow is normal. Probably that would be of much greater help than the global cardiac output. It would be of much greater help than the global cardiac output.
RL also can be used, or is it only saline for the amniotic?
No, saline was previously used. Nowadays, they are using lactate.
Do we have any definitive endpoint as to how much it has to be infused, the rate of infusion? Do we have any definitive endpoint for that to judge how much we have to infuse?
Is that the fetus is bathed in it, and like when it is out, the cord is bathed in it. So when the uterus is open, you don't see any space in it. So you don't measure. I suppose it depends on the size of the uterus. So the uterus is like a big pot. So it is filled till it is visible. But we have to be very aware that there's a lot of absorption occurring there, and also any open venous sinuses. So mothers become hypervolemic very quickly.
So we have to reduce the IV in the mother, IV fluids.
Very drastically. We should not infuse any. We just keep an open line. That's it.
And for any blood loss, we replace the blood loss with blood instead of going for a hysteroid
That is what is recommended, but strangely, we have not had any blood loss. In the 5 exits we did, there was no.
What is the maximum blood loss you had encountered during exit procedures, ma'am?
Max 1 liter, not even 1 liter, just 500 ml to 1 liter or so. I think everybody's standing on their toes, so I mean, things are okay. I think when one becomes careless, I think these things start to happen. But at the same time, we cannot rule out the possibility of massive PPH, and also postpartum uterine atony has been reported even 24 hours after the procedure. So the patient has to be kept under observation.
And if the fetal cocktail administration, if it is IM, it is okay. But if it's going to be IV, we go in for the umbilical vein.
Yes,
we're going via the umbilical vein.
Yes, IM is sort of more rapid and sure, so they don't waste time in it. That's the reason why. Otherwise, umbilical vein is very good. It is sort of more sure. Sometimes in one of them, the pediatrician placed a catheter.
Yeah, that was the next question, ma'am. Do you place a catheter?
And then that's very useful because then you can use it for infusion, especially for tumor excision. It's very useful because if there's a tumor, sacrococcygeal teratomas bleed a lot.
That
we need to give the child weight blood. So something like 10 ml per kg blood is given. So for that, we need those catheters.
You've answered all my 3 questions in a row. Now I'm running short of questions.
I feel very bad. I apologize to all the listeners.
Ma'am, nothing, nothing actually. We are privileged to have you. No issues, ma'am. It's a technical glitch. No issues, ma'am. And if at all the RBCs have to be transfused for the child, we go in for a leukodepleted or...
Leukodepleted one. That is fairly standard now. Even for the mother, leukodepleted one is okay. So, but we don't go for the whole blood or anything, which was previously the thing. So in babies also, we go for leukodepleted RBCs only. And the babies, actually, there was a problem of whether they can form a clot, especially when one goes percutaneously and does aortic valvuloplasty. So do such small babies, are they able to form a clot? Because if they don't, then they will just continue to bleed and you made a whole aorta. So it is found that they actually can make a clot. It may not be as strong as an adult clot, but it is sufficient to seal the chest wounds and the aortic wound. So that was one of the concerns raised.
Okay. And after exit procedures, uterotonics, how long do you administer uterotonics?
Uterotonics are, we give it over 24 hours. Just like after a normal cesarean section, because the moment you withdraw desflurane and nitroglycerin, much of the effect is gone. They're very reversible, short acting, so you don't have to worry. And if at all the uterus is suffered, it's probably because of the saline. I always feel that it kept distending it, so what will happen? But we have not had to give anything, and they're anyway under surveillance in the ICU. So every hour the uterine bone is, so just a 24-hour oxytocin is what is required.
Yeah, just a situation. I don't know if it could be hypothetical. Like if there is any airway obstructing syndrome or any tumor or any cavus syndrome, but if it is a breech presentation, then what do we do, ma'am? We deliver and then will have to again like apart from the head, the rest of the child has to be again placed inside the uterus.
As a cesarean section only, we will not allow her to deliver vaginally anyway.
No, not vaginally, like via the incision also.
When the incision is made, then you can rotate the baby and take it out. Because for other procedures also, the baby is turned around, whatever suits the surgeon. So we can ask we make the baby come out by the head and not by the breech. Okay. So that's a good question there. Yeah. And a lot is dependent upon the ultrasound, which is done just before that, the echo, the cardiac. We used to have the CTG. We kept the CTG because at that time we didn't have the echo for the baby. So the CTG activity was the only thing which would tell us. But by turning around the baby, and if the maternal blood pressure is okay, generally nothing happens.
Yeah, that was like turning around is possible.
Turning around is possible. They do versions and other things. Okay. So, and in the presence of a controllable thing, there's a uterine incision also. So
yeah, because like we don't want the uterus to be completely empty. No, we want the uterus to be filled with.
No. The amnio infusion starts. In fact, there is something called controlled amnio reduction, which is the first step. So before the uterine incision is made, the obstetrician aspirates a lot of amniotic fluid. Okay. So it's so that uterus is not bulging and ready to expel the amniotic fluid and then start going to labor. So it's already made a bit lax, and then after the infusion starts immediately. So the uterus is never empty in that.
Okay. Right, ma'am. And the CMAP that
We didn't. I didn't show you the slide where there's so many people shouting in the room. There's no place to move. And when we had twins, you can imagine. So we had to have 3 workstations and 3 everything. And along with that, the rigid bronchoscope, the warmers. These are very pertinent, and also it shows that you read a lot about it and you know very nicely.
I all learned from you, ma'am. Thank you so much, ma'am.
And I'm really my sincere apologies to Dr. Johnson and yourself for
nothing. Seriously, we enjoyed. You had made us visualize. It was like like a Hollywood movie kinds. So thrilling it was to watch all those things, and how you had employed your stewardship and leadership role there. That is more important in this.
No, the best part was that the one senior obstetrician came after everything was much over. She said, so there's nothing happening. Like everything had already happened. So it's like that we take on everything on our head. But I think it's very good if the anesthesiologist manages it, because I think we know a lot about administration, which other people.
They are a better team leaders than others.
And also we see more into the thing than others. So.
Yes, ma'am. Thank you for those 2 videos. It was wonderful, really. Thank you for having you here, ma'am. We are blessed to have you here. Wonderful lecture. Wonderful lecture. I don't have words to say.
Add something to everybody's knowledge. That's all. So if the PGs have any issues, you can just ask them to mail.
Yeah. We would just message you and get your answers, ma'am. Thank you so much. Thank you so much.
Again, Dr. Johnson, thank you very much. Where is here tonight? You can hear me. And Vinothini, of course, thank you so much. Thank you for remembering me, basically.
Ma'am, thank you, ma'am. How can we forget you? Thank you so much, ma'am. I take this opportunity to thank Dr. Anju Gupta, ma'am, and Dr. Rajeshwari, ma'am, for their wonderful lecture and imparting knowledge to us on these 2 most important topics and upcoming topic. And I also take this opportunity to thank IDRA and Anesthesia TV for being part of us. And happy Diwali to all of you. Thank you so much. Thank you. Thank you, ma'am.